and the role of a healthy endothelial cell for its antithrombotic effects. And then we talked a little about hemorrhagic disorders, which will be explained more in the hematology chapter. Then we talked about thrombosis, including venous and arterial thrombosis. And now we continue with the embolism. What is embolism? So, in thrombosis, a vessel is narrowed or obstructed. This is a vessel, and in thrombosis, this is thrombosis, which is composed of red blood cells, platelet, and fibrin. And why are you speaking? And thrombosis, as I said, its difference with the blood clot in the post-mortem is what? What is the difference between thrombosis and the blood clot that is seen after death, post-mortem?
Not attached to the vessels.
What?
Not attached to the
The
vessels.
thrombosis can go from this side to another side, transport.
No, it's gross picture, it's appearance. I explained you.
It's not
What is the difference?
lighter color, lighter,
What?
lighter, and it's not attached to the vessels.
It has dark and lighter areas, paler and darker areas in thrombosis, which makes the appearance of laminations. And so the darker areas, which are red and more composed of red blood cells, and the lighter areas, which are composed of platelets and fibrin. And so it has an appearance of lamination. Lines of what? Song. Lines of song. But in post-mortem state,
It's not.
just the blood clot is composed of red blood cells. It's completely reddish and overlaid by a chicken fat-like structure. And so by these features we can say that this is developed after death, and if the picture of the mass is something like laminations and darker and paler areas, it shows that it has been developed before death. And these blood clots are not bound to the vessel wall, but thrombosis is bound, is attached to the vessel wall. And now what is embolization? Embolization is most commonly is due to thrombosis. That's why we also, instead of embolism, we can call it thromboembolism. This thrombotic material or some part of it separates, dislodges, and starts to travel in the circulation. This is called embolization. But in addition to this thrombotic material, anything else, such as fat tissue, such as even a foreign body, and air, amniotic fluid, anything that moves in circulation is called embolism. So, an embolus is a detached intravascular solid, liquid, or gaseous mass that is carried by blood from its point of origin to a distant site where it often causes tissue dysfunction or infarction. But most commonly this is due to thrombosis. That's why we use the term thromboembolism. But in addition to thrombosis, it can have other causes that we will mention. So the most common type of embolism is pulmonary embolism. And most commonly, this pulmonary embolism is due to deep venous thrombosis. As I told you, venous thrombosis is most commonly developed in veins of legs. And most importantly, in deep veins of legs. Those veins that are present at the upper knee, popliteal, iliac, femoral veins. So deep leg veins are prone to thrombosis due to immobilization of the patient, even if the patient has some hypercoagulability states being acquired or hereditary. This deep DVT or deep venous thrombosis is the most common cause of pulmonary embolism. Pulmonary embolism causes about 100,000 deaths per year in the United States. In more than 95% of cases, pulmonary embolism originates from leg DVTs, deep venous thrombosis. So, most commonly, pulmonary embolism is due to deep venous thrombosis. All right. You see this picture, this is the thrombosis from deep veins of leg that has traveled to pulmonary artery at this bifurcation area and has given a form of saddle. That's why it's also called saddle embolus. Do you know what is saddle? Saddle of a horse. So, saddle embolus. So, it's formed in branching areas. So, a larger artery then branches at this area, at this site of branching, it forms a saddle-like obstruction. So according to its size, it obstructs those vessels that are smaller than the size of the embolus. And so any tissue distal to this obstruction is prone to ischemia, hemorrhage, and infarction. But the sensitivity of tissues is different to embolism. Some organs have a dual circulation, such as a lung has circulation from pulmonary arteries and bronchial arteries. So these kinds of organs are more resistant to embolism, to obstruction. That's why infarction is less common in these kinds of organs, such as liver and lung. And also liver is circulated with hepatic artery and portal vein. So it's called dual circulation. But some organs, such as the spleen, kidney, they have end arteries and they don't have dual type of circulation. So this depends on the anatomy of the organ. So in organs such as spleen, kidney, these are more sensitive to infarction because they don't have dual type of circulation. But in lung and liver, infarction is less common. And the type of the sign is most commonly hemorrhage and congestion. I've explained you congestion last times, that we have two types of increased blood volume in a tissue: hyperemia and congestion. What is the difference between hyperemia and congestion? Hyperemia and congestion are both due to increased blood volume in a tissue. I have repeated it maybe for 2 or 3 times. What is hyperemia and what is congestion? Hyperemia means increased inflow in a tissue. This is the tissue, for example, the artery that brings blood to this tissue. It shows increased blood flow. For example, due to increased physical activity. So more blood streams to the skeletal muscle, and this is called hyperemia. And the kind of blood that is increased in tissue is hyperoxygenated. But when there is decreased blood outflow, so there is some problem in this vessel that cannot outflow the blood, so some part of the blood will back up in the tissue. So due to some narrowing or increased blood volume here, such as right heart failure. In right heart failure, when the volume of blood in right ventricle is more than the capacity of the lung to pump it to the left side, there the more volume of blood will go back to the venous system and cause this will show increased blood volume in a tissue, most important of which is liver. So congestion is due to decreased blood outflow from a tissue, and that kind of blood is deoxygenated, and so has lower oxygen, and we use the term cyanosis when the level of oxygen is lower. So the tissue becomes bluish in color and it's called cyanotic. So one of the most common organs that shows congestion is liver, chronic passive congestion of liver. And I explained to you that what is the gross picture of chronic congestion of liver. What is the term used? I've shown you that picture for maybe 3 times. This picture. Next Friday we have exam, midterm exam, 5 April, all groups, 201, 23, from inflammation chapter and this hemodynamic chapter. But it seems that you haven't studied. So hyperemia and congestion. This is the picture that I showed you several times. This is liver, but you see the color of the tissue is not all the same. Some parts are darker and the surroundings are lighter. What is the meaning? The darker areas are the necrotic areas due to lack of nutrition and oxygenation. And this is the microscopic picture when the central liver cells show necrosis, coagulative necrosis, and the peripheral hepatocytes are healthy. And the gross picture is this, that the darker areas are necrotic areas and the lighter are the healthy cells. And this is called nutmeg liver. Nutmeg liver. I have repeated it maybe for 4 times. Nutmeg liver is the sign of chronic congestion in liver and is most commonly seen in right heart failure. Another name for a right heart failure is cor pulmonale. Cor pulmonale. Or maybe in Latin, cor pulmonale. Pulmonale is liver, is lung. Pulmon is lung. This is right heart failure, and increased blood back up to liver and the venous blood, which is hypooxygenated, causes chronic passive congestion in liver with areas of central necrosis, and giving the picture of nutmeg liver. What are the cells, macrophages, called in pulmonary congestion, in congestion of liver? What are those cells? Nobody knows? Chronic congestion of lung. This nutmeg is seen in chronic congestion of liver. But what types of cells do we have in congestion of lung? Chronic congestion of lung. I said that due to increased blood flow to the lungs, macrophages start to phagocytose iron, the excess iron, and they are hemosiderin filled. And these iron-laden macrophages or hemosiderin macrophages are called which cells? Heart failure cells. And again, I have repeated it for 4 times, more than 4 times. Heart failure cells. Heart failure cells, they heart failure cells. So you see heart failure cells in lung, in alveolar spaces of lung. They accumulate hemosiderin, which is iron. So nutmeg liver in chronic passive congestion of liver, and right heart failure is the common cause, and heart failure cells in alveolar spaces of lung due to left heart failure. So, embolism, pulmonary embolism, which is the most common type of embolism, I said that its most common cause is deep venous thrombosis. Thrombosis in deep leg veins. And when it occurs in branching or bifurcation area of pulmonary artery, it has the form of saddle, and so that's why it's called saddle embolus. And there is the risk of multiple embolization in lung. When there is only a single lung embolus, there will be a risk of multiplication of this embolus. That's why a patient who has had one pulmonary embolism is at high risk for more. This embolization becomes multiple. There is a term called paradoxical embolism. What does it mean, paradoxical embolism? It means that if the patient has a congenital heart disease, this is heart, for example. This is the septum, septum that it separates right ventricle from left ventricle, and sometimes congenitally this septum is open at some area between the right and left ventricle, and the blood here from left ventricle can go to right ventricle, and maybe later the reverse type of streaming from right to left. So this, when when an embolism is present in a vein, so a venous embolism, through this septum can go to the arterial system. This septum that is open due to congenital, which is called ventricular septal defect. This is the most common congenital heart disease, ventricular septal defect, that the septum is open congenitally. When an embolism is present in a vein, due to the presence of this septal defect, it can travel to arterial system, arterial circulation. And this is called paradoxical embolism. So an embolism, you imagine that the patient has deep venous thrombosis. This travels to lung, and if the patient has a ventricular septal defect, the origin of this thrombosis is in vein, but by passing through the septum, it can reach the arterial system, and that's called pulmonary paradoxical embolism. Most pulmonary emboli are symptomless since they are small. 60 to 80% are clinically silent because they are small. So it's dangerous for the patient, and suddenly it can bring the patient to emergency situation. And also sudden death and right heart failure, which is cor pulmonale, can also be seen in these patients. And the clinical picture of the patient depends on the size of the arteries that are involved in embolism. Embolic obstruction of medium-sized arteries are less risky than embolic obstruction of small end arteriolar pulmonary branches. So the clinical picture of a patient with pulmonary embolism depends on the size of the arteries that are involved. The smaller the artery, the worse is the prognosis, the worse is the obstruction of the vessel. That's why when medium-sized arteries are involved, and because of having dual type of circulation in lung, there is less risk of infarction in lung, and the more common type of clinical picture is hemorrhage. It causes pulmonary hemorrhage, not infarction. But if it is severe, it can cause. This infarction is more common when smaller arteries are involved. Multiple emboli, as I said, if a patient has a single embolism, this patient has the risk of multiple embolization. And multiple emboli over time may cause pulmonary hypertension, means hypertension in pulmonary artery, and right ventricular failure. What does it mean, systemic thromboembolism? When we use the term systemic, it means that this embolism is present in arterial circulation. So after the most common type of embolism, which is in lung, it's called pulmonary embolism. And its most common cause is thrombosis in veins, and especially in deep leg veins. Systemic thromboembolism is the
embolization in systemic circulation. And these 80% of these embolization, they develop in heart, from heart. It's the thrombus in heart, as I told you, is called mural thrombi. Mural thrombi. So 80% of systemic thromboembolism develop from thrombus in the heart. So it's different. You see that thrombosis in lung arises from veins, thrombosis in veins, but embolization in systemic arteries arises from thrombosis in heart. So these are asked in examinations, that the origin of embolization. So pay attention to the origin of different embolizations from different organs. The lung from deep venous, deep leg veins, and systemic emboli, most of them arise from heart. But the remainder, it says that 80% arise from intracardiac mural thrombi. But the remainder originate from aortic aneurysm. As I told you, aneurysm means dilation of a vessel. And the most common, so this is a normal vessel, and sometimes the vessel can be dilated due to the weakening of the vessel wall. It's called aneurysm, is dilation, aneurysm. And maybe both sides are dilated. So it can be bilateral. And this dilation area, it increases the risk of thrombosis, because blood here in the dilation area has a slower flow, which is called stasis. The normal type of blood flow in vessels is laminar type, but if it becomes abnormal, it's one type is stasis, when the blood stops at dilation areas, which is called aneurysm. And it's common in aorta, and especially in abdominal aorta. Abdominal aortic aneurysm is, in abbreviation, is called AAA, abdominal aortic aneurysm. So, in aneurysms, thrombosis that is seen in dilations, the most common area is aorta, has the risk of also embolization. Also, if a patient has atherosclerotic plaque, that I explained you, has the risk of ulceration of that atherosclerotic plaque, thrombosis, and then some particles of this atherosclerotic thrombotic materials can separate and circulate in circulation and cause embolization. What are valvular vegetations? You don't listen today. I am surprised that today you don't listen. So, valvular vegetations. The valves of heart, for example, aortic valve, mitral valve, these tricuspid valve, that is for the right side, and the mitral valve, tricuspid valve, mitral valve. These valves have cusps that atherosclerosis can be seen on these valves. And this atherosclerosis then can become infected or ulcerated, and they can be a source of embolization. So these are called valvular vegetations. So vegetation means that we see some nodules, some masses on the valves, on the surface, under it, or the opening areas of the valves. These are called vegetations, and if they start to travel in circulation, it can be a cause of embolism, but less common than the most common type. So these are called valvular vegetations. And venous thrombi that I told you, the cause is paradoxical emboli. So 80% of systemic thromboembolism arises in heart itself, but the remainder are aortic aneurysms, atherosclerotic plaques, valvular vegetations, or venous thrombi. And here, again, the organs that are involved in systemic thromboembolism. In pulmonary embolism, thrombosis from leg veins travel to lung, but if there is a mural thrombus in heart, then this can travel to other tissues. These are also asked in questions. Most common of these systemic thromboembolism are in lower extremities. So here is different. If a thrombus is, imagine there is a thrombosis here in right or left ventricle, this is a mural thrombus. And imagine this thrombus or some part of it starts to circulate in arterial system. If anybody speaks, I will ask question from you, or who else? So this is an important topic. If you don't listen, you can't understand. What is a mural thrombus? What? So listen. Mural thrombus originates in heart. So the thrombosis in heart is called mural thrombus. This thrombus starts to circulate in our arterial system. The most common area is lower extremity. So again, here the legs are the most common areas that arterial or systemic thromboembolism is seen, 75%. So here is different. In pulmonary embolism, DVT, deep venous thrombosis from legs travels to lung. But here, the thrombosis from heart travels to legs. This is the arterial thrombosis, and this is venous thrombosis to lung. This is heart and travels to arteries of legs. So pay attention to this. More than 75% of mural thrombi travel to lower extremities. And this time the patient will have, if the lower extremities are obstructed, there is the risk of gangrene of the leg. So gangrene. Necrosis for extremities, for necrosis we use the term gangrene. Gangrene is used for extremities. So here is different that these thrombi in heart, they rest in lower extremities. Less common areas are brain, 10%. So from heart, they can travel to brain. 10% of cases. And the other organs include intestines, so intestines or bowel tract. We can have bowel infarction, or kidneys, spleen, and upper extremities. So after these lower extremities are brain, 10%, and less common areas are intestines. Obstruction of the arteries to intestines will cause bowel infarction. And this stroke or brain infarction, cerebral infarction, or to kidney and spleen. So these are less common sites for arterial embolization from heart. So this is important to know, that we can prepare some questions from this part. And it's clear that the consequences of systemic emboli depends on the sensitivity of the tissue, the anatomy of the organ that it has, dual circulation or not, the cells are sensitive or resistant to infarction, and the diameter or caliber of the vessels that are obstructed by the embolization. So the end result will be tissue infarction, that after the embolization we will discuss infarction. What is fat and marrow embolism? We said that the most common cause of embolization is thrombosis. That's why we use the term thromboembolism. But we said that any gaseous, liquid, any or even foreign body materials can cause embolization. What is fat and marrow embolism? Due to severe accidents and bone fractures, extensive bone fractures, some part of the bone marrow, including its fat or even the hematopoietic cells, can enter the circulation and cause fat and marrow embolization. Here the site that they're embolized is lungs. So this is bone marrow embolus in pulmonary circulation. This is the vessel, its wall, and here is a fragment from bone marrow. This part that you see some cells, they are the blood forming cells, and these vacuoles are fat tissue, and this part is again composed of the red blood cells, platelet, fibrin. So this particle has come from bone marrow. So the patient has had bone fractures, especially in long bones such as femoral fracture, and this is the result, bone marrow embolus. So if only fat is seen, we call it fat embolism, but usually it's together with blood forming elements, bone marrow, and we can see both fat cells and some blood cells. So, and also something to know is that after cardiopulmonary resuscitation, you know cardiopulmonary resuscitation? During this procedure, there is the risk of fat and marrow embolization. It's common, but since the size of the embolization is not big, they are small, most commonly they are symptomless and they have no clinical importance. So it's one of the causes of fat and marrow embolization is cardiopulmonary resuscitation. So, fat embolism occurs in some 90% of individuals with severe skeletal injuries, bone fractures. But fortunately, less than 10% of these patients have any clinical findings. So it depends on the size of the fat and bone marrow embolization. Less than 10% they will be dangerous for the human being. So this is the origin of fat and marrow embolization, and they travel too long, the pulmonary circulation. And what are the clinical pictures if a patient has pulmonary embolism with symptoms and if it's big and has caused problems? Pulmonary insufficiency, so has respiratory problems and neurologic symptoms, anemia and thrombocytopenia. And in 5 to 15% of the cases, it's fatal. So, what is the clinical picture of a typical patient with fat embolism syndrome? 1 to 3 days after injury, there is a sudden onset of tachypnea. Tachypnea, do you know? Rapid inspirations. So tachypnea, tachy means rapid. Dyspnea or shortness, and tachycardia. Heart rate is increased. Irritability and restlessness, and at last it can progress to delirium and coma. So a fat embolism syndrome, typically this time 1 to 3 days after the injury, has these signs of dyspnea, tachypnea, tachycardia, which can progress to delirium and coma. And since the platelets are bound to those fatty tissue that is embolized, so the number of platelets are decreased in the patient, which is called thrombocytopenia. Another name for platelet is thrombocyte. If it is decreased in number, it's called thrombocytopenia. And here you see that the platelets bind to that embolus and are decreased in number, so there is a risk of bleeding for the patient. So this thrombocytopenia will cause bleeding. And also these are sequestered. Sequestered means accumulated, and the organ that sequesters cells is a spleen. Sequestration of platelets, sequestration of red blood cells occur in spleen, and that's why the patient, together with thrombocytopenia, maybe has anemia. So these features will be present in a patient with fat and bone marrow embolism. Air embolism. I think that today there are many students that are absent. Ashwin is present. Alan Joy. Ali has gone to a conference. Sarah.